Finally, let's look at two cases. The first case, a 28-year-old man, previously excellent health, present within a 2-week history of fatigue and worsening fever. He has been convinced by his family to seek medical attention because of noticeable pallor and the recent onset of a particular rash at his extremities. His physical examination is remarkable for pallor, the particular rash, pharyngitis, and gingivitis. He does not have lymphadenopathy or hepatosplenomegaly, and the remainder of the examination is remarkable. The patient has been given a peripheral blood test. The complete blood count shows that hematocrit is 19%, anemia. White blood cells are 32,000 per microliter, leukocytosis. Platelets are 14,000 per microliter, thrombocytopenia. From the differential, we can see 85% of immature cells. From the smear morphology, mature neutrophils are not seen. Platelets are markedly decreased. Red cell morphology is normal. The immature cells are large with an open nuclear chromatin pattern, prominent nucleoli, and few granules. In rare cells, rod-shaped objects, the hour rods, can be found. Let's think about what further history, examination, and laboratory evaluation is indicated, and what should be the pace of this workup. From the above examination, the patient may have hematologic disease with a high probability of leukemia, should be admitted in hospital immediately. And next, we need to know his personal and family history. We can see here, further history reveals no personal or family history of hematological disease. He has 3 siblings, all in good health. And the further dental examination reveals a typical abscess in first molar, which means he has an infection. Then the MICM examination should be done immediately. The bone marrow aspirate shows that a nearly uniform population of cells resembling those seen in the blood. Some contain all rods, Bistroли peroxidase positive, and positive for specific esterase, but all other stains are negative. Flow cytometry shows the bloods to be strongly positive for CD34, CD13, and HLA-DR, and negative for all lymphoid-specific markers. Upon review of this data, the leukemia is classified as AML-FAB-M2. So, what initial therapeutic steps should be taken? What long-term interventions should be planned? After all the examinations, as the WBC is high, the patient is agitated and began on allopurinol. The infected tooth is extracted, and the empirical antibiotic therapy is begun. He began on prophylactic antifungal and antiviral therapy, and within the first 24 hours of admission, he began on chemotherapy. Several days later, the results of the cytogenetics are available, showing a translocation of chromosome 8 and chromosome 21, which means he may have a good prognosis. His parents and siblings are asked for blood samples to begin histocompatibility testing. The patient becomes pancytopenia with a fever and about 2 weeks after induction chemotherapy. His WBC begins to recover. A repeat marrow examination shows reduced numbers of myeloid cells, but evidence of normal myeloid maturation and no increase in blasts. Then the patient recovers with a normal CBC and a normal marrow examination. From the above results, we can see that the patient gets CR. Histocompatibility studies show that he is a good match to one of his siblings. With his relatively favorable cytogenetics, he might also help be managed without immediate transplantation. He should move to consolidation therapy for the next step. The second case, a 16-year-old female presents with the recent onset of fatigue, headache, and repeated epistaxis over the past week. She has been in excellent health and has no personal or family history of serious illness. She has 4 siblings. Examination reveals pale conjunctiva and multiple petechiae on her lower legs. Abdominal examination suggests a slightly enlarged spleen. The remainder of her examination, including a neurological examination, is normal. The CBC shows that hemoglobin is 8 grams per deciliter. Anemia. WBC count is 110,000 per microliter. Leukocytosis. Platelets are 45,000 per microliter. Thrombocytopenia. From the differential, we can see 85% of immature cells. The smear morphology shows normocytic, normochromic red blood cells with the occasional shift cell, polychromasia. Dominant population of blasts, which are moderately large cells with little cytoplasm and prominent nuclei, surrounded by an abnormal nuclear chromatin pattern. Platelets are reduced in number. Let's think about what abnormality is apparent from the CBC. What further studies are indicated? From the CBC and the smear, the patient should proceed leukemia ICM immediately. As she has a palpable spleen, radiological examination should be done, including evaluation of both the chest and abdomen by computed tomography, CT. The possibility of CNS involvement should be addressed by examination of cerebrospinal fluid, CSF. From the bone marrow aspirate shows nearly total replacement of the marrow by a uniform population of blast cells, which one phenotype is early pre-B cells. Cynogenetics shows hyperdiploidy, but with no specific translocation identified. The chest CT is normal. The abdominal CT confirms the presence of mild splenomegaly. The CSF shows increased numbers of large lymphocytes with the identical phenotype as the marrow blasts with normal protein and negative cultures. So now, what risk category does this patient fit into? What initial therapeutic interventions are indicated? Young children with early pre-B cell ALL have an excellent chance to cure. Adults, on the other hand, may achieve an initial complete remission but are rarely cured. When presented with a case such as this, it is often difficult to determine whether the patient fits into the childhood or adult category of ALL. Positive factors in this patient include B-cell ALL phenotype, hyperdiploidy, and female gender. Negative factors include her age, the high blast count, and evidence of CNS involvement. As a result, this patient falls into an indeterminate risk category. Due to the negative factors, this patient should probably be intensively treated with remission induction chemotherapy, including intrathecal chemotherapy, followed by consolidation and maintenance. She and her siblings should be tested for histocompatibility in anticipation of the need for allogeneic HSC transplant, especially if remission is not immediately achieved or if early relapse occurs. Okay, that's all for this topic. If you are interested in AL, here we recommend 2 books that you can read. Thank you.